Hello, my name is Kayla Witherspoon, and today's date is December 26th, 2022. Today I'll be presenting on case number 1 and case number 4 of the case studies for Unit 4. Case number 1. In this case, a newborn female has developed lethargy, hypothermia, and apnea after 24 hours. A complete panel was ordered and the abnormal results are an initial blood ammonia level at 314 micrograms per deciliter, which quickly rose to 600 micrograms per deciliter. And urinalysis shows elevated orotic acid levels at 473 micromoles per liter, and citrulline level was slightly decreased but normal. So let's start off by going over the process of transamination and deamination. This is important in the concept of removal of ammonia from the body. So transamination occurs when an amino group is removed from an amino acid and transferred to a keto acid. This is catalyzed by transaminases and aminotransferases. Deamination refers to the removal of an amino group from a molecule, which is catalyzed by deaminases. The excretion of ammonia is achieved by converting it to urea in the liver. So ultimately, that is the goal. So overall, transamination leads to the catabolism of excess amino acids and converting essential amino acids into non-essential amino acids. And this is achieved through several cycles. The first cycle we'll go over is the urea cycle, which is essential to remove excess ammonia from the blood. In this process, ammonia is converted to urea through 5 steps using various enzymes and is ultimately excreted through the urine. The level of arginine and glutamine can detect a defect in the urea cycle. Elevated levels of ammonia may result in hyperammonemia or a urea cycle disorder. So a normal urea cycle starts in the mitochondria, which is in pink here, where carbamoyl phosphate is formed from ammonia and bicarbonate through carbamoyl phosphate synthetase, or CPS. So you can see carbamoyl phosphate synthetase 1 here, reacting with carbamoyl phosphate. And so orthonine transcarbamylase, or OTC, uses the carbamoyl phosphate to make citrulline. Citrulline is then transported from the mitochondria to the cytosol by SLC25A15. In the cytosolic stage, arginosuccinate synthetase or AS is the enzyme used to produce arginosuccinate from aspartate and citrulline. And this reaction is driven by a hydrolysis of ATP to AMP and phosphate. So the arginosuccinate is cleaved by arginosuccinate lyase into fumarate and arginine. The arginine is then broken down by arginase into ornithine, where it is then transported back to the mitochondria. Urea is a byproduct of this process of arginine into ornithine, which then passes to the blood and is excreted into the kidneys. And you can see here that the carbamoyl phosphate synthetase is activated by N-acetylglutamate, and it is also a rate limiting step. So the amount of enzyme that you have is crucial to the amount of ammonia that you can remove. The urea cycle takes place in the liver. So in the next slide, we're going to go over how ammonia is transported from skeletal muscle to the liver via the glucose-alanine cycle. So this is the glucose-alanine cycle. On the left, you'll see this represents the skeletal muscle, and the process is used to enter the bloodstream. And on the right, you will see the processes that take place in the liver. So amino acid is transaminated to produce glutamate. So oxidative deamination liberates ammonia here and here to be transported to the liver, where it can take place in the urea cycle. So important reactions to consider are ammonia plus glutamate plus ATP. It creates glutamine, which is the safe and the non-toxic form and safe storage of glutamate. And the reverse reaction is shown below that, with glutamine plus water yields ammonia and glutamate. And you can see here through alanine aminotransferase that is what is transaminating the alpha ketoglutamate into glutamate, which can then be converted to pyruvate and eventually to glucose. And this is how amino acids are used for gluconeogenesis. So gluconeogenesis of amino acids occurs in the fasted state. This makes sense because there's no carbohydrates available since you're fasting. Therefore, amino acids are used for fuel instead. And this is summarized in reaction 3. You can see here that amino groups are broken down to alpha ketoglutarate, which is broken down to glutamate, broken down to pyruvate, broken down to glucose. So the glucose-alanine cycle transports ammonia from the muscles to the liver, and the urea cycle ultimately transforms that ammonia to urea, which can then be excreted. So the most likely deficiency of this infant would be an orthonine transcarbamylase deficiency, or OTC deficiency, due to several factors. The reduced citrulline would be expected in this condition because orthonine is used to synthesize citrulline. So although it's considered within normal range, the value is decreased, which points to an OTC deficiency. And the least likely deficiency would be arginase, arginosuccinate, and arginosuccinate synthasase, because these happen downstream of the ornithine transcarbamylase. So without it, it affects the processes, ultimately reducing the urea cycle and the production of arginine. In case number 4, a 58-year-old woman presents to the emergency room with progressive weakness, shortness of breath, diarrhea, intermittent numbness and tingling of the lower extremities, tachycardia, smooth tongue, low hematocrit, and loss of balance. Megaloblastic anemia is suspected. Deficiencies common in anemia are iron deficient anemia, B6 or folate deficient anemia, and vitamin B12 anemia. So megaloblastic anemia is often due to a vitamin B12 or coalamin, and folate deficiencies, or vitamin B6. These are both necessary for the synthesis of DNA. So in a deficiency, this inhibits nuclear division, leading to megaloblasts, or precursors to mature cells in the bone marrow. So on the left here, this is a peripheral blood smear of someone with megaloblastic anemia. You can see the macroovalcytes. These are much larger RBCs than normal. You can see the increased size and shape. It's a lot more oval and less. You can even see the indent here where the oxygen should be attached. The depression is differently shaped and sized than a normal RBC. And you can see teardrop cells, which shows a premature pinching off of RBCs by the spleen, which is also a sign of megaloblastic anemia, as well as hypersegmented neutrophils. So these are all, this is a peripheral blood smear of someone with megaloblastic anemia, and these would be consistent with the findings in this patient. So it's important to determine the differences between a vitamin B12 deficiency and a folate deficiency. There are some clinical manifestations that are different. In a vitamin B12 deficiency, it may present with pain caused by a peripheral neuropathy, affecting the lower extremities specifically, such as your hands and feet. And loss of balance is also characteristic of a lack of vitamin B12. And these symptoms may help differentiate the deficiency. We can say that this patient is experiencing a vitamin B12 deficiency because of the neurological symptoms, the neuropathy, and loss of balance that this patient is experiencing, as well as the gastrointestinal issues. Thank you for listening to my presentation, and I hope you have a great day. Thank you.